palliative care matters, because palliative care isn't just a specialty, it's something we all do. Subscribe wherever you get your podcasts. In today's episode, I am delighted to be joined by two special guests, and for the first time we have a co-host. Fatia Kiange is the Executive Director for the Centre of Health, Human Rights and Development, as the former Programmes Director at the African Palliative Care Association, and as a social worker and public health leader and activist in Kampala, Uganda. I'm very pleased to welcome you, Fatia, today.
Thank you, Dr. Jane Bates. I'm glad to be here, and thank you, listeners, for having me and for giving me an opportunity to have this conversation with you.
Wonderful, thank you. And of course, the two researchers, Yakubu Salifu is a lecturer at Lancaster University and a co-director there of the University Africa Research Hub, as well as being the founder and CEO of Compass in Ghana. And Dr. Kennedy Nkoma, a Global Health Research Fellow in Palliative Care at King's College London. So a warm welcome to both of you.
Thank you very much.
Thank you so much, Jenny. Thank you. And thank you, Fatia, for joining as well. Thank you.
Great.
I'm happy to kick off. So we've noted that within some geographical settings, the informal care is the way to go for people with chronic diseases and palliative care. So we wanted to look at first hand the sort of huge gap that exists for people who need palliative and end of life support. Be it emotional, social, and financial support. And just to kind of put it in context, these are people who provide such services without the structured, formal support to help them to execute that, services. So we wanted to know how existing family and community network can be, strengthened. But before that, we wanted to find what the challenges are for them to kind of know how we can strengthen that.
Great. Fatia, do you want to chip in with a question or two?
Oh, thank you. Thank you, Dr. Jane. Yeah, it's a very informative. I find it a very informative study and with great potential to impact policies, service improvement, but most importantly, capacity building for both the caregivers, the patients, but maybe including the policymakers. And one thing that I observe. So congratulations, colleagues. Dr. Yakubu and Dr. Kennedy, because I really found it a useful study. I just observed that most of the papers that you came across were focusing on cancer and fewer on other palliative care conditions combined. And then I wondered, could you comment on whether there was anything on caregiving related to the more recently highly infectious diseases that we are seeing, the disease outbreaks like COVID-19, like Ebola? I'm coming from a spirit of we have actually lost some former caregivers to such conditions, but and there are conditions that clearly also benefit from palliative care. So I'm just curious to know whether there was, and I see that you at least looked at COVID-19. Did you find any research around caregiving?
Yeah. Thank you very much for that question. So, and I absolutely agree with you. COVID-19 was kind of very global, and when it comes to Ebola, it was kind of very concentrated in Africa. So we did look at all kind of chronic diseases with the such terms and some kind of inclusion and exclusion criteria. But I think due to the sort of the search terms and the inclusion and exclusion criteria, we did not find specific, disease situations where, the caregiving was about COVID or, Ebola, probably because of how quick the whole kind of, process goes in terms of getting the disease and the time that maybe the person will recover or die. And you did talk about the fact that most of the study were, cancer. rather than non-cancer. And that is also obviously true, because if you look at the development of palliative care, the main kind of focus was originally on cancer patient, but with time it has come to include all other disease conditions. So we were not very surprised in seeing that cancer was actually leading in that. But as you rightly noted, we did find other non-cancer conditions as well, and that is something that we have looked at in a different paper with different colleagues. So later on we could kind of look at that as well. I don't know whether Kennedy has something to say.
Yeah. Just to agree with you in terms of that, to say, okay, yeah, we did include all the main chronic illnesses, as you have rightly said, but it is interesting that none of the studies talked about Ebola or COVID-19. Yeah. Of course, there were some publications about COVID-19, but not really focusing about caregivers' experiences, but maybe healthcare professionals' preparedness about COVID-19 and the like. Yeah. So I guess maybe this also, maybe we'll discuss this later in terms of like it is informing like what needs to be done in terms of work to do this work in among patients or caregivers who had COVID-19 or look at for somebody who had COVID-19. Yeah, thank you.
Thank you so much, Dr. No, it's interesting because when I look at the thematic areas and all those factors that are positive factors for caregiving in the settings that we are focused on in this research, then you think, would those be the same? Would those provide that positive enhancement for caregiving for these highly infectious diseases? Perhaps, but it would be an interesting area as the team noted, and maybe it could be something we could recommend they could consider for research and recommendation. But maybe the other question I could ask is again, when you look at the study and the findings, still you see it skewed towards the caregiver experiences as well as compared to the experiences of patients. And I would really like to check in their views. Is it that the patients did not have views around caregiving? Is it that we don't have enough research around that? I was just wondering why, if when you look at the quotations, the experiences via the quotations in the research, you find that most of them, or if not all of them, are caregivers and not so much the patients.
Yeah. Thank you for that very useful question. So we did acknowledge that during the data analysis. So if you look at the various teams that we have, that is 5 in number, we've kind of incorporated both the perspective of the patient and that of the caregivers. But as you've alluded to, the voice of the caregivers was much more, greater as compared to the patient. And I think it's not quite surprising because it depends on the stage at which the patient are. And in most of the settings where the study was being, conducted, most patients express their care needs through the caregivers. So that is one of the of the reason, but that is not to also say that we did not include that. So at the design stage, we were contemplating whether to look at the perspective of either the patient alone and the caregivers alone.
I'm just coming from a funny, a curious side still, that it would be interesting what the views of the patient would be, especially and their experiences of caregiving. Would it be that they are equally stressed seeing their family member get stressed? Would it be them feeling guilty for keeping somebody at home and not going to work? It would be quite an interesting side of the voices of caregiving. But yeah, I hear you loud and clear that it's very difficult to separate the two.
So as you talked about, we use a meta-synthesis approach, guided by Thomas and Hardin. So we thought that it was really, really important to kind of look at the studies together to bring a different interpretation of the individual findings of the studies. So one key advantage of a meta-synthesis is the fact that it helps you to kind of generate a much more, interpretive understanding of issues that the individual studies will not be able to, to do. So that was one key advantage of that. And one of the lessons that we learned was that, by just coding all these, studies and, doing constant comparison, it forces us to kind of engage deeply with each of these studies. And mind you, we were looking at studies from different cultural contexts.
Yeah, so there were 7 in Africa, 6 in Asia. Yeah. But there's quite a concentration in certain countries, Ghana, Iran, and so on, which is interesting. I mean,
yeah,
it means that, we've got a lot of data from those countries, but maybe obviously thin from other sites, which is, again, it's pretty common in palliative care research, isn't it? That maybe we're missing stuff, but at the same time, you tried to gather all that together, which is very good effort. Yeah.
Okay. Well, just to also comment a bit about the meta synthesis itself. So in terms of like what I learned or the lessons, like the experience of really pulling together different experiences and the different context, as Yakub said, and the disease conditions I found that quite interesting, especially when that data was put together and then you look at the findings that are much common across different disease conditions. So that really is interesting, and that's why I think we need this way of actually doing research, of at least bringing data together, because we know that one of the reasons we're doing a review is to bring the evidence together when it's been done, so that we can possibly easily inform policy. Yeah. Of course, there are issues about other people argue why doing a meta-synthesis or this, but I guess it's a good way of summarizing findings together.
How long did it take? Because it sounds like it's quite a lot of work.
Yeah. It took us nearly 2 years.
Wow, it's a lot of work.
But I also think I wanted to check in that I see you used in the such terms like life-threatening, terms like people with palliative care conditions, terms like chronic. I know you used chronic debilitating conditions, but some studies could have chronic conditions and maybe could be missed. Then a lot of home-based care, because I was so interested in home-based care because it's much closer to caregiving, the area, to informal caregiving.
So when we are doing the initial search, we planned to use search terms like life-limiting, life-threatening, or debilitating conditions, and then what we found that it was very difficult to come up with a very search that can produce studies that are manageable. But we used those disease conditions that we consider life-threatening, like, for example, diabetes, stroke, COPD, all those chronic illnesses. So we had to search each disease condition, and then when we executed that, we were able to come up with a proper output, and then the studies that were manageable. Yeah. But of course, we do understand that every research has got its own limitations. We considered home-based care as a mode of care, and then there are also different ways that can be provided. So that's why we actually didn't include that. But I guess maybe another review focusing on that may be suitable. Yeah. Yakub, maybe.
Yeah. Thank you very much, Kennedy, for that. Very insightful. So the other reason for, the low and middle income country is that we use the WHO's definition of who a low and middle income country is. So if you look at our search term, we even spelled all those countries one after the other, so that we are very, very sure that we've covered all the corners. You know, the term resource poor, I think what we mean within this context is maybe the sort of infrastructure, the health infrastructure. And yesterday when Kennedy and I were having discussion, preparing to that, human resource is also a resource. So within these settings, we have a lot of human resource providing that. So within the context of the people, we are looking at the kind of, let's say, medical facilities, but no human resource. So probably we need to kind of look at that terminology.
Yes, I was in fact, Jakub has actually responded to say that yes, indeed, there can be resource poor settings in high income countries, and it would be interesting how these findings look like for for such settings. But also in low and middle income countries, you can also be able to find high income settings. So in fact, as I was reflecting on that, I wanted to check in with you. Do you think this argument can be utilized in changing the long-standing global classification of countries and allocation of resources? Because definitely this classification of poor resource can easily influences the allocation of resources. So it's quite an interesting thing. And do you see it being able to influence change in terms of how these terminologies are used for global health?
Kennedy, do you want to come in?
Yeah, I can come in to say, okay, thanks so much. It's quite a useful discussion. I don't think I have really a different answer in terms of what Yakub already alluded to. But I think, again, reflecting on this, I've now realized that I think I've been using these terminologies like interchangeably to mean everything, like resource poor, resource constrained countries, and the low and middle income countries. So for me, it means the same, but actually, um, there is a difference, of course, when you say low and middle income countries. That is based on the WHO classification, based on how much the country, how much money the country has. But when you say resource poor country or resource constrained, we mean things like availability of infrastructure. Yeah. So maybe my general comment there would be like, I think it's really important to realize that you can be from what we would call a resource poor country or a developing country, so to say, but we have huge resources. So, for example, what we have found in this study, the importance of, for example, family support, engagement that comes from the support is something that you don't see it here in the UK, having lived in both countries. Yeah, I have a very good, strong support when I'm in my country, but here I don't really experience that. So that itself is a huge resource that some people miss here. And actually, it's good that Jane, you brought in the issue of up to now, up in the UK, they have a minister of loneliness, which means it's a huge issue. It's not something you can talk about in the African context to have a minister, for that portfolio. Yeah.
And it's interesting, isn't it? I mean, it may be something that needs a little bit more writing about. Of course, it's useful and important to have categories, because if we don't have categories, then you can't do your searches. But I also think it does, to a certain extent, affect how we frame in our thinking, how we're framing, how we view different places. So, Fatia, can I ask you to try and briefly ask something about the question of females in caregiving, before we just look at some of the faith issues and then maybe try and wrap up? Thank you.
Clearly, recognizing the burden of caregiving to be often falling on women, which we all know. But what is interesting in this particular research is that you highlight that the caregiving roles of men are overlooked and undervalued. So I actually wanted to check in. Did you come across any studies that made reference to men as caregivers and their role, their kind of roles and motivation? That I really wanted. I was curious to know whether you found any that are actually making reference to men caregiving.
Yeah. Thank you very much for that beautiful question. And I think it is something that we kind of spend a lot of time on. We all know that, for decades, women provide majority of unpaid, care globally. Indeed, with some of the studies that we looked at where, some women had breast cancer or cervical cancer, it was either, their husbands or maybe male adults who were also providing care. So what we want to draw attention to is that we want to kind of look at how the dynamic, the change in caregiving role, we should also kind of conscientize ourselves that, we shouldn't downplay the role that men are, doing, so that to kind of encourage that. If you look at most of the informal support and structure, it's kind of in a way designed to make the care as, a work for women. So if we really want to encourage men to kind of take some of this care role, then we need to not overlook some of the work that they are doing already and what they can also do to enhance the care that is being given. Sometimes the culture also affects how care is received and delivered. So example, with men with, let's say, prostate cancer, in some society, prostate cancer is associated with licentious behavior. So if somebody has a prostate cancer, the person is even shy talking about it. And it will be very difficult to get support, or even in some situation where they are bold to talk about it. Because some people think that they are being licentious, they may not also want to, provide care. And if the same thing comes to even HIV/AIDS, which is usually through sexual transmission. So some people may think that somebody has lived an immoral life and therefore they are not there to provide such care for them. So it kind of also linked with some of these kind of cultural issues that we want to kind of throw more light on.
It's very interesting, isn't it? That sense of the disease itself and the sort of disease understanding, how that can impact caregiving.
Yeah.
That's, I think, something that possibly we may miss some of that unless we understand how specific illnesses are understood, whether it's stroke, whether it's a type of cancer, whether it, medically we can know that it's not infectious. From a caregiver point of view, they don't necessarily know that. So people's belief and health beliefs are quite critical, aren't they?
Yeah.
Within this, I mean, yeah, I think it's quite a hot issue, I think, about.
It's very tricky, and some of the diseases, because it's kind of life limiting and very terminal, some people also associated with they being cursed, and
Sure.
if that is the belief, they don't want to be associated with somebody who has been cursed for that kind of curse to also follow them. So in order to kind of advocate for the care within such context, and I'm very happy that Fatia, that's your sort of area, and to kind of build capacity, we need to kind of kind of face some of these myths, face some of these kind of beliefs, to kind of try to dispel such beliefs and to help people to provide care. Palliative care is about providing care to meet the needs, the comfort, the dignity, and to relieve people of pains and symptoms, really. So I think it's really critical to kind of look at it from that angle as well.
I know that spiritual care, faith, is very central to palliative care, to holistic care, and it really, really works. And even this paper found the same. But also, I know that increasingly there are situations where faith has been used in ways that are harmful to patients and negatively impacting care outcomes. I'll give you a person living with HIV not to take their medications, claiming that, no, you will be healed. When you pray, you will be healed. I've seen that. And I've even seen it amongst healthcare workers themselves when they have treated people who have become well, but when it's them, they actually will listen to that. I definitely didn't see that come through the paper, but on the ground, I know it's an issue. I know there are issues of giving false hope. rather than, of course, we know that in palliative care, giving the right information in the right amounts is very important, and really clarifying expectations. But I know that sometimes faith-based care or spiritual care sometimes will cross to giving false hope. So I wonder, did you find anything on this, or would it be an area worth researching actually, especially in low and middle income countries, because it's a reality that people will even abandon medications because somebody else has told them under the guise of spiritual care that you will heal. Even if you don't take medicine, you will heal.
Yeah, thank you. However, the very good aspect, and we kind of carefully coined that one, having faith as a coping mechanism. So those people, in as much as they believe that their disease is at the very advanced stage, they also have that kind of, faith in, going through that and, lessening that. And in most of the sort of intervention that perhaps from this one we need to propose is to kind of bring some of these faith-based organization into the delivery of palliative care. Because if people believe in what the faith, leaders say, or what they kind of, tell them, it is really, really, if you want to make any change, it is really important to also involve them.
Yeah. So I guess when we say holistic or associated approach, at least incorporating faith healers in the provision of palliative care is the best mode of care really to go. That's what is required. Yeah.
Great. As we wind up, one of the aims of this podcast is to try to bridge findings, of those of you working full time in the research community to those who are doing clinical practice, particularly thinking of people who are working in the global south. How do you want this research to have impact? What are you kind of looking for? Who would you want to read this paper, and what might you want them to know or do? But are there any thoughts from either of you?
Yeah, thank you very much. The most important thing is for people to be aware of the challenge. So that said, we also like policy makers and healthcare leaders, community-based organization, and here policy makers not only at the national level but at the local level, because we look at most of these things happen within the local communities to advocate for the inclusion of all these people who are involved in the provision of the care to kind of deliver a care that is very culturally appropriate and also very kind of inures to the needs of the people. So these things that we've kind of highlighted in the study, is something that we wish to communicate to help strengthen policy, and just to also kind of advise, one policy doesn't fit within every society. So we need to be very sure what works for us within a particular, geographical area. And sometimes there's a need to kind of adapt, accept the things that work and, just ignore those that wouldn't work, and kind of provide the care that meets the needs and the aspiration of the people. Thank you.
Yeah. Can I also say something? Yeah, I think it was also good to see that you invited Fatia, because for me, I've known Fatia as someone who has direct links with the policymakers. So I think that's another good way of disseminating this work. Yeah.
I'm very grateful, Fatia, that you've taken time to be today in this conversation, but also the time that you've given to review the paper and put thoughts into questions. So thank you very much for that. Are there any sort of closing thoughts that you want to share today?
Yeah, I think reflecting on this paper and this conversation, and as a person who is so passionate about palliative care and worked in palliative care for a long time, and now very much in social justice in health, I think that other angle of social justice in health, this paper, I think one thing that it's bringing out, and really that is worth advocacy, is the fact that the team is commenting on comprehensive social welfare systems and health insurance and highlighting that caregivers and patients resort to loans. And this is typical of low and middle income countries and access to health, which becomes a direct social justice issue in health. And I see this paper as an important like coming who did even come up with important advocacy recommendations, given that it brings out the issue of out-of-pocket expenditure and how this impacts palliative care patients and families. I see that as a big thing for me and for advocacy using this paper. But also the fact that the families are getting loans, the fact that there is financial support from neighbors, as the example from Indonesia, they having to choose between food and medical care. It brings questions around equity in health, issues around human rights in health, dignity, privacy, and really the link between caregiving challenges, health systems challenges, and universal health coverage in terms of catastrophic expenditure. So this can be a paper that can really be used to advocate, really informing advocacy, informing policy, and improving service. And I want to thank you, Dr. Jen, for inviting me to this space. I think this is very important.
Yeah, it's our pleasure to be here.
Palliative care matters, because palliative care isn't just a specialty, it's something we all do. Subscribe wherever you get your podcasts.